take a show of hands here. How many of you have walked with a loved one through the end of life? Okay, a lot of you. I suspect if you have not done that personally, you will at some point with your parents, most likely. Every once in a while we have people who've walked through this with a spouse or a sibling, and God forbid that you would ever have to walk through this with a child. I spoke on this at a church about a year ago and had a woman approach me afterwards, and she said, we just walked this journey with our 3-year-old child. Wow. And she wrote a book about it. She gave me the book. I started it one afternoon, and the rest of the day sort of went before I put the book down. I mean, absolutely riveting. But this is where ethics and morality really touches where we live. Right? Now, those of you who have walked with a loved one through the end of life, another show of hands here. How many of you were involved in decisions to remove some form of life support? Okay, 1, 2. Okay, all right. Now, third and final question on this short quiz. Of those of you that raised your hand, how many of you felt like you were prepared for the decisions that you had to make? Okay, 1. Why was that? Because you had thought about this before?
Yeah, this was just a few years ago. And
okay.
I didn't study bioethics before.
Okay. I suspect most people in our churches who have had to do this feel completely unprepared. I spoke on this in my own church over Memorial Day, and about probably 85% of the people raised their hand to the first question of having walked with a loved one. And virtually no one raised their hand when they said they felt well prepared. And so what I want to do, the goal for this session is to give you the tools to walk with people through the end of life. Okay? And there's a whole lot to this in terms of bioethics. But there's also a pastoral dimension to this that's really important that I think we need to attend to, because at the end of the day, what will carry the argument against euthanasia and assisted suicide is the way we in our communities care for people at the end of life. Because what drives the movement toward euthanasia and assisted suicide is the fear of dying in isolation, in pain, and without resources. What we found is that when people have support and when they have their pain controlled and have some control over the decisions that they make, they want to live. Now that shouldn't be a huge surprise. But when there's a positive alternative to assisted suicide, people will choose it. The state of Oregon is a really good example of this. Oregon, that's been about probably 10 years ago now, became the second state out of 3 to pass a law legalizing assisted suicide. What they've discovered over the time the law's been in place is how few people have actually availed themselves of the law. And in fact, I think the public health officials have been pretty surprised at that. And the reason for it is that the way, for one, pain management in the state of Oregon is considerably ahead of the rest of the country. But there's also an ethos where people are cared for in their communities. And there's an alternative that's perceived to assistance in suicide. And if their pain is managed well, then people generally want to live and don't take advantage of the law. Montana just recently legalized assisted suicide. It'd be very interesting to see if that works out the same way. I think there's less hope for major metropolitan areas where people live basically separated from their extended families. And people are much more apt to die alone and in isolation. Right? So that's sort of that on the bigger picture of that. That's what's important on this. That at the end of the day, we present a positive Christian vision for what death and dying looks like, as opposed to just saying no to euthanasia and assisted suicide, which we should be doing, but not without an alternative. And some of the alternative, there we go. Don't put that up on the web. Some of the alternative involves how we deal with medical treatments at the end of life. Okay? People generally, when it comes to treating people at the end of life, what people are most afraid of is the sort of a runaway train of medical treatment that can't be stopped. And that most people are very afraid of lingering in really compromised health situations. Okay? So anyway, that's where we want to head with this. And this is really, I'm so delighted that my church gave me the opportunity to talk about this. And I was inundated, both in between services and after, with people who were just grateful that we've kind of come out from the closet and talked about this a bit. They've been very grateful for that. So that's a secondary goal to this, is for you guys to have some of the tools to be resource people in your churches, for your pastors, and better yet, for the healthcare professionals who are in your churches. I suspect that the average physician, nurse, social worker, hospital administrator I'll bet you they would fall out of their chairs if they heard some of this addressed in your churches. And I suspect that the healthcare professionals who are in our churches consider the churches and the pastoral staff some of the last places that they would look for resources on this. And I think that's too bad, because you guys are the ones who live life with the people in your churches. You know them, you know their values. You guys and the pastors in your church are the best equipped to walk through the end of life with these folks. I've been beating on my seminary students for this for years, saying that they should be calling you, not the hospital chaplains, though those are good folks generally, but they shouldn't be taking a lot of this advice from their physicians or from hospital personnel who don't know them, probably don't share all the components of their view of the world. You're the ones that do that. The hospital personnel certainly haven't lived life with them. You have, and you guys need to be the ones who are walking through this with them. Okay? So I want to give you some tools. Hopefully we'll do more than just give you enough to make you dangerous. That would be nice if we could pull that off. Okay. Now, just to be clear about this, we're talking about three different things here. Okay? TLS, I'm going to use the initials for this. TLS stands for the termination of life support, also known as the withholding or the withdrawing of treatments at the end of life. Okay. Second, we'll refer to PAS, or physician-assisted suicide, which is quite different than removing a treatment. And then third, we'll say a little bit about euthanasia, probably not quite as much, because there's no place in the United States where that's legal today. But euthanasia is different than assisted suicide, primarily because euthanasia occurs when the patients are too sick or debilitated to actually utilize assistance. They have to be directly, I mean, it's the direct intervention of the physician, not for you personally, of course, but as opposed to in assisted suicide, the physician will prescribe, advise, and supervise the patient taking his or her own life themselves. Okay? Usually they will prescribe a life-ending dose of some sort of medication that will stop their heart and slow their breathing to virtually nothing. And they'll advise them about how to do this, and then they'll be sort of right there on call if things don't go quite as planned. Okay? And then with euthanasia, they'll just basically put the drug into the IV line and take care of it like that. There are a variety of cases of euthanasia being performed today around the world, both without the patient's consent and without their knowledge. So we'll talk a little bit more about that toward the end. Okay? Now, what set the background for a lot of this discussion was a landmark study, which you can read if you want to wade through this in the Journal of the American Medical Association. This study was done in the mid to late 90s, and it was 10,000 patients. And in order to get into the study, you had to have one of about a dozen or so clear life-threatening illnesses. Okay, so admission to the study, if you qualified for the study, that was bad news about your condition and your prognosis. This was a study you did not want to qualify for. Okay? What they tried to measure, and granted, and there were some assumptions that went into this, but now we'll try to spell those out. One, they tried to discern if and when DNR, do not resuscitate orders, were written. Okay, everybody familiar with what that is? That's if you have a heart attack, nobody's going to perform CPR on you. Okay? Generally, what they concluded was that if you didn't have a DNR order, or if it was written in real close proximity to the time you died, chances are you were going to receive CPR when, for one, the chances of it doing you any good were small, but also the chances of it being harmful to you were really significant. I mean, CPR is designed for basically people our age whose heart stops suddenly and unexpectedly. It was never designed for people who are sick and debilitated and have to have it chronically done. In fact, if we'd ever performed CPR on my father-in-law on his dying days, they would have broken most of his ribs, probably punctured a lung, and probably 50-50 chance of leaving him worse off than had he actually died. So anyway, that's the assumption that if you didn't have a DNR order, or it was written just within a day or two before your death, that you were getting more aggressive treatment than was warranted. Okay. Second, they tried to assess the way patients and physicians communicated with each other at the end of life, and they just used the preference for CPR as one indication of how well the communication was. That is, if the patient and physician were in agreement about what the patient's CPR preference was, what that suggested was that they'd actually sat down and talked about it. Okay. If they hadn't, then that was evidence of, let's just say, very poor communication at the end of life. If the physician doesn't know that, then chances are they haven't talked about hardly anything of substance at the end of life. Third were the number of days spent in the ICU or on mechanical ventilation. And now again, these are terminal illnesses that people are dealing with. They are not going to get better. They are going to just go progressively downhill. The assumption here is that what's appropriate for most of these patients is a far less aggressive level of treatment than you would get in an ICU or with full mechanical ventilation. In basketball terms, we would say that's a full court press for some people when it's clearly not warranted. Right? Now, there are some exceptions to this. There are some times where even at the end of life, surgery would be appropriate for comfort purposes. Right? For example, somebody with stomach cancer at the end who's got an intestinal blockage. Okay? Surgery to remove that blockage is really important for them to stay comfortable. And so not every instance that you be in the ICU would be inappropriate, but as a general rule, for patients who are terminally ill and have just a few months to live, the ICU is not the place that they want to spend their time. Okay? Fourth, and this was probably the most important one, the frequency and severity of pain that was experienced by the patient. Now this was it's a little bit harder to quantify this. But what they did is they did it on a scale of 1 to 10, 1 being pain-free, 10 being worst pain imaginable. And if you see some hospitals, they actually have a series of faces to describe the increasing levels of pain. Okay? And then hospital resource use, that was sort of a moot point at the time. It's far less of a moot point today because statistically, just as a general statistic, you will spend roughly half of all of your health care expenses in the last 12 months of your life. When arguably, now that's not for everybody, but in many cases, that the last 12 months of your life is the time when the treatments will do you the least amount of good. Right? Now that's not true for everybody, but in a lot of cases, that is true. Okay? Now, what they found, they actually had an educational intervention with the physicians, which didn't really do much. So the findings were the same before and after the education. Almost half the DNR orders were written within 2 days of a patient's death, which is way too late in the process. And patients were having CPR performed routinely when it clearly wasn't indicated. Roughly half the physicians did not know of patients' CPR preferences, which reflects an abysmal level of communication at the end of life. Now, this I think has changed a little bit, but the conditions for which this needs to be done have deteriorated. So I think physicians are more sensitive to this at the end of life. But physicians today are busier than they have ever been before. And most physicians just don't have time for extended conversations at the bedside about the end of life. And increasingly, the physician you see in the office is not the same one that you will see in the hospital. I mean, increasingly, healthcare organizations are going to specialists who only see patients in the hospitals and they don't have an office practice. And so it may be that the physician who's followed you in the office will never see you in the hospital, which in my view is not, in terms of the care of patients, is probably not a great development. And it's where efficiency conflicts with good care for patients. This is where it started to get a little bit dicier. Over 1/3 of these irreversibly dying patients spent at least 10 days of their last hospital stay in the ICU. And what that indicates is a level of aggressive treatment that is way over the top. for basically patients who belong in hospice care. They're in the ICU. Okay? And then the one that really got people's attention was that 50% of patients or families, if the patient had died, reported being in moderate to severe pain in the last few days of their life. That, I would suggest that's unconscionable for that to happen. Now, that I think has gotten a lot better today. Hospice care has become more widespread. If you've had a loved one in hospice, I suspect you've come away from that looking at hospice personnel as if not angelic, pretty close to it. I mean, the hospice people who took care of my dad, they're my new heroes. But to have people suffering like that in pain, that's why people want assisted suicide on the books, because of that. And I think if we treat people's pain adequately, for the most part, they won't be interested in assisted suicide. Okay? Now, a follow-up to this was done about 10 years later. In fact, the conclusion is, this is a serious understatement. One commentator put it a little bit more bluntly when he said, if you are dying and in a hospital, get out. And if you're not in a hospital, don't go there. Now, I think it's improved significantly, but the vast majority of people die in a hospital setting, essentially surrounded by strangers, with tubes, treatments, and technologies that they probably don't want, but just haven't bothered to say so. Okay? Here's the fourth question on your quiz. How many of you have an advance directive or a living will? Okay, 1, 2, 3, 4. Good for you guys. Shame on the rest of you. No. So, I'm kidding, sort of. Jimmy, it's unusual that somebody your age would have one, but you've been down this road, so you know the drill on this. For the rest of you, if you were to come down with a serious illness and you were to lose the capacity to make decisions for yourself, who in your life would know what your preferences are at the end of life? You hope. Yeah. How many of you, if you're married, how many of you had this conversation with your spouse? Okay, good. Okay, good. That's terrific. Now, there may be good reason to go ahead and write it down too, because I don't know if your spouse may be different than mine. I'm not totally persuaded that my wife has the stomach to do what I want done at the end of life. I'm not sure about that. I mean, I could see her getting a little weak in the knees and, keeping me going indefinitely on treatments and technologies that I don't want. Okay? So I used to think that all you need to do is tell somebody and talk to them about it, until Terry Schiavo's case came along.
That's when I got mine.
You're wise to do that. If she had written her wishes down, I suspect none of this would have gone to court at all. Okay, and we'll talk about her case in a little bit, because that's one of the screwiest cases of all time.
Yeah.
Question?
Yeah, that's really important because of the reaction that the medical officials have by any of the family members against the DNR is still very powerful. It is. And just no charge for this, but it is illegal for a physician or a family member to override a validly written advance directive. That's illegal. Okay? And the person you designate
to make decisions for you, let's put it this way, that is not an interpretive function. Right? They don't get to interpret your living will. They don't get to look at that and say, well, that's not really what she meant. Or I think I got a better idea. Right? Right? So I'd say it's especially important to write it down if the person who you know will be making decisions for you, you may not be completely sure when push comes to shove that they'll do what you want. Okay, now there are limits on what you can want, of course. And I'm glad my wife would not have the stomach to assist me in committing suicide, or authorizing euthanasia for me. But I am far more afraid of lingering on indefinitely and having somebody delay my homecoming than I am of having the plug pulled prematurely. Now, if I had my way, it's probably illegal to require this, but if I had my way, you couldn't pass this course without completing an advance directive. But I think the law would suggest I don't have the authority to do that. So, but it's a really good idea, and the form that the state of California has is actually a pretty good one. It's not perfect, but it's a good start. And I would definitely talk about this with your physician. And once it's filled, those of you that have them filled out, do you know where it is? Okay. Does your physician know where it is? Probably not good enough. But
I can't control that.
no, I know. But I would make sure that your physician has a copy of it in your chart. Because if you get to the hospital and nobody knows where that fool thing is, you might as well not even have it. Okay? So anyway, end of sermonette. We'll do that. Now, the second, this is really important, I think, as we walk with people through the end of life. This was basically a consortium of Catholic hospitals basically said, we read a lot, we hear about what people need and want at the end of life, but we've never really asked people ourselves to tell us what they need and want at the end of life. And so the Supportive Care of the Dying Project set out to do that. They interviewed hundreds of terminally ill, dying patients, their families, their caregivers, and particularly the people who survived them after their death. And basically asked them, what do you need and want at the end of life from the healthcare system? Some really interesting things that they said. For one, they said they want to know the truth, and they want it communicated regularly and in a timely way. They want to know what their diagnosis is, what their prognosis is, and where we're going with these tubes, treatments, and technologies. Okay? This is a huge ethical issue with some patients from some parts of the world who basically take on the burden of decision making themselves and take it off the patient. Okay? In the United States, that's illegal to do unless the patient himself or herself says, I want so-and-so to make decisions for me. We had a case I consulted on some time ago where this was a woman in her 60s with Hodgkin's disease. And her son, she didn't speak any English, she was Hispanic. And her son was serving as the translator. But he wasn't letting information go back and forth about her condition. So all she knew was that she was sick and that she was going to have a treatment that was going to make her sick to her stomach and cause her hair to fall out. And that's all she knew. And so we actually ended up getting another translator in there with a son in the room and asked her, do you want to know what's your condition, your prognosis? And in her own kind of demure way, she said, of course I want to know. At which point the son, we actually had to remove the son and get another translator in there full time. So it's very clear people want to know the truth. Okay? Second, which if you've ever cared for someone who is at the end of life, you'll resonate deeply with this. Is that dying patients and their families want to be regarded as a single unit. What they mean by that is that whatever affects the patient also affects the people who care for them. That's not the way we treat it. We treat the people who care for them as virtually invisible. And we assume that they're just sort of like Energizer bunnies that can continue to go on and on and on. But if you've ever cared for a dying person, you know that's not true. And that the decisions about the patient have a dramatic impact on the people who care for them. Third and fourth are really important things that I think often go without being accomplished. And that is dying patients and their families both expressed a huge need to close the loop relationally before they die. And to give your loved ones an opportunity to take care of any unfinished business and say the things that you've always wanted to say the things to your loved one that you will say at their memorial service. And I'm so grateful. I got to tell my dad everything I wanted to tell him before he died. I'm so thankful for that. That would have been tragic had I not had the opportunity to do that. And granted, some people, they get run over by a bus, and you just don't have the chance to do that. But when we do, you have to realize how important that is to family members. And you guys can help. You can encourage them to say those things before they die. The best thing you can do, and this is really what the families were so clear about, is they need a heads up that this day is coming. And it's not that hard to predict. I mean, people with terminal illnesses know that they don't have forever to take care of this business. And frequently, what happens is that families are given so much hope and optimism by the medical community that when the physician finally says, we probably ought to stop treatments and move to hospice, the family, they're completely unprepared for that. And so they've been getting hope, upbeat optimism, and then finally now these treatments are futile. And what happens, the families, that's why they dig their heels in and say, what do you mean you're going to stop these treatments? Not a chance. But they also miss the chance to close the loop before they die. That's so important. And I think you guys can help the families, because some families they're just in denial about this, and you're not going to break through that. But others need to hear it from somebody close to them, from their pastors, from somebody in their church or in their small group. And I mean, I've had countless physicians say, where is this person's pastor? Where is their community to help us resolve this conflict? Because the family's saying, keep going, and the doctors are saying, what on earth for? And that's what you guys can help them with that. So just be aware that how important that is to give a heads up. And you can even couch it optimistically. You can say, look, the doctors are saying this will probably go well, but you ought to be prepared, given Dad's age and his general condition, which is not that great. It wouldn't be a huge surprise if there are complications. Okay? My dad, he died in October 2 years ago. In August, he had a 10-hour surgical procedure. I'm still not quite sure why. They said it was for comfort purposes, but that sounds a little extensive to me for comfort purposes. Nobody once said to any of us what kinds of decisions we would have to make if complications ensued. He was 81. I thought, thankfully, I had thought about this a little bit before, so I had already had this discussion with him. But nobody said, we anticipate that this might go well, but, it wouldn't be a huge surprise if there were complications at his age and his general health. And particularly if you have a parent or a loved one in a nursing home. In fact, we had a term for these folks which was not particularly complimentary, but people would come from the nursing home to the hospital and back and forth, and we started calling them frequent flyers. Because it was just, we knew they were going to be back. And rarely do we ever say to the family, maybe not on this visit, but on the next one or the one after this, you're going to have decisions to make. But nobody, that kind of heads up is really unusual. And I don't have confidence that physicians will do that. I'm a little more confident that nurses will. But this is where I think there's a huge place for you guys to be a part of that conversation. Question you want to raise about that? Yeah.
Just a question. I'm glad that you're bringing this up. My thesis is actually going to be on end-of-life care. I'm in the beginning stages of this. And so one thing that my understanding, I'm a social work student, and my understanding is a lot of times nurses and other individuals end up telling the families, hey, you need to prepare for this instead of the actual physician. And I'm not sure if that's really due to more of the physician being busy or kind of why that is, it seems like.
Well, I'd say if that were universally true, that would be, I think, a substantial improvement. Because nurses are the ones who, they're on the front lines. And they're the ones who sometimes they get it before the physicians do. And the social workers are usually not far behind. And you guys earn your keep navigating this stuff at the end of life. Because I suspect you've seen already, there is huge family dysfunction that comes out at the end of life, right? There's more dysfunction per square inch in an ICU waiting room than in a whole lot of other places. And there's guilt and regrets and all kinds of goofy stuff that keeps people from making good decisions about the end of life. And so they're looking to you to help them sort of navigate their way through this. But I think there's a really important component to that. Sometimes physicians don't empower anybody else to have those conversations. And though I think physicians' training is getting better, one of the things that this study showed that people agreed on is that there's a general lack of education for physicians on this. Now, I think it's getting better, but the pace of practice doesn't contribute much to this either. And most physicians are really well trained to cure disease. They're not trained to care when cure is no longer possible. Yeah.
Well, and that's what I was thinking when you were talking, and not sure that I would have a popular view, but in many ways, I think that it's unfair to expect physicians
I
to
agree.
be social
I agree.
workers, or, I mean, I want a physician that's gonna fight that disease and be an expert in that, and not necessarily be a focus on my family issues and, you know, the rest of that. I think we need to have that taken care of, but I don't think that's the physician's role necessarily.
They're definitely not trained to do that. But as you know, that doesn't stop them from forging ahead sometimes. And granted, some physicians do this really well. You know, others don't. You know, that's a tough thing. It's a tough conversation to have with people. And I think most physicians actually distance themselves from these kinds of conversations as a survival technique.
Well, yeah, and just as a focus, I mean, their focus
Right.
really is to battle the disease.
Right.
And to do everything they can do in that arena. And then,
Right.
you know, once that's lost, then maybe they've lost a little bit of their desire to keep in the fight, but they're humans.
Well, I think this is getting better, but I think some physicians take death personally.
Mm-hmm.
I mean, oncologists that treated my dad, you know, they did not want to give up. And they probably should have given up before they did. I mean, they were still suggesting experimental treatments and, you know, research study, you know, protocols. And, you know, I told my dad probably, 4 or 5 months before he died that, you know, we know where this is headed. That, yeah, I mean, the only thing further treatment will give you is a little bit more time. But nothing, I mean, and we knew that, nothing was going to turn this around. But progressively, the cost physically got higher and higher. Yeah, they tried, he had 3 rounds of chemotherapy, different regimens, and each one of them killed him faster than it killed the cancer. It wasn't doing squat against the cancer, but it was killing him. And his ability to appreciate the rest of his life went down the drain. And so I told him when he could still make decisions that you can tell the physicians to stop whenever you want to. And I said it would be okay to do that, and I don't think he realized quite how costly this final surgery was going to be, because he was in the hospital for 5 weeks, and you know, that's the last place. That is the last place you want to spend, you know, a month of your last 3 months of life.
Not to mention how miserable he probably was.
Oh, it was terrible.
I'd like to explore that further in your thoughts. I had a friend who came down with cancer in his early 70s, and he wanted to do the chemo and all that stuff. And I had a hard time with that because he's a Christian, and chemotherapy and all that is just
Nasty.
havoc on his body, and he ended up dying, you know, about a year later. I just thought, what do you think? Do you think it's better to just not go through that?
Well, I don't think it's right to generalize like that. We'll get to, I mean, sort of anticipates where we're headed with this, but theologically, I think it's acceptable to say stop before you die. I don't think that we are required to do everything at all times and at all costs to keep people alive. The term we use for that is called vitalism. And the sanctity of life and vitalism are not the same thing. Right? Now, that raises a really important question then about under what conditions is that okay? Because I suspect if your friend was 40, maybe that's different. Now, I don't want to, but not strictly based on age, but, you know, maybe if the prognosis is better, or, you know, the burdens and benefits might weigh out a little differently, then that might be different. And of course, there are times when, you know, it would be unconscionable to withhold or withdraw treatments, right? I mean, if people are going to get better, of course, you treat them. But, you know, these are the cases where the prognosis is clear and very poor, and, you know, they are, you know, I mean, they may not be imminently dying, but the trajectory has been set already. I mean, with my dad, there was no doubt what the end game was going to be. You know, eventually, this was going to overtake him. And what that in-between time looked like, we had a lot of say over. Okay, now, I don't think, you know, I'm not sure looking back we did all the right things, which really helped me appreciate. I mean, I've thought about this a little bit more than the average person, but doing this in an academic setting and doing this next to the kitchen table with my dad is a very different experience. So, I mean, you gotta, you know, just be aware that, you know, it's just different when it's personal. And so I get it that families have a hard time with this, you know, and that conversation was hard to have, but it needed to be done. Because the physicians certainly weren't going to have it with him, and I don't think my mom had the stomach for it, because she needed to be at the kitchen table too, hearing it. Yes.
Have you any indication that ODs are any better than MDs at these end-of-life issues? And then a second comparison?
I can't speak to that. I don't know.
Do you know if there's any, have you ever seen any difference between physicians trained at Christian schools like Loma Linda, Baylor versus public schools like Irvine or Davis?
No. I don't think there's a huge difference. The physicians who have been trained, I mean, hospice physicians, they get it. It just depends on the person. Some ethnicities, it's harder than others. I don't know. I'm not sure I can account for. We had a really tough time with Middle Eastern physicians, with them stopping treatments. I'm not sure what accounts for that, and some Asian physicians had a really difficult time. Asian families had a difficult time stopping treatments. African American families had a difficult time with stopping treatments. I mean, those are broad generalizations, but it's a tough conversation to have, and you know, but somebody's got to do it. Yeah, Mike.
To her point about a specific person, I remember C.L. Recruit had written that he needs to know an awful lot about the person, an awful lot about the disease, and also an awful lot about how the person's responding to the treatment in order to help the family in that decision. And I know in my case, when my dad passed away, he was on an event, and you know, he was unresponsive for a couple days. He had a stroke, and had previous small strokes prior to that, and he was 73. And so we had to make a decision, and it was a tough one. And I thought through, you know, like you had thought about these things, but then when the family got involved, it became dysfunctional. And
all hell breaks loose. Yeah. See, what I tell my seminary students is if you want to get better at this, go hang out with a hospital chaplain for a little bit, and go make rounds with him or her, and ask specifically if you can sit in on an end-of-life conversation. You know, I think most chaplains would be thrilled to have people come along sort of like a ride along with the paramedics. But I don't know how many my students take me up on that, but that's another place to go. Okay, now are we any more on the pastoral side? Any other questions you want to raise about that? Yeah.
Do you think that, I mean, obviously it changes the way you approach the session, but like age, the age of a person who's going through something. So if you're 21 and you get diagnosed with cancer versus, you know what I mean?
Yeah. I do think that makes a difference. I don't have a problem giving treatments a little more of a chance the younger the person is. Partly because the person's ability to recover from really aggressive treatments is better generally the younger they are. I think there's also something about, my dad had lived a full life. He'd accomplished everything he'd set out to do. And so, the only thing he had left to accomplish was to beat this, which he was not going to do. And so I think there's, the 90th Psalm tells us that our days are, 70 or 80 if we have strength. And I think it's okay to say, the person's lived a full life. And in general, I think it's better that we are the ones who say that about ourselves and our loved ones, or if we don't, the state will say it. Because, spending half of your expenses in the last 12 months of your life is an unsustainable system. And so it's much better if we manage this ourselves than to force the state to do that. But I would give a lot more slack, I think, especially with a child, than I would with an elderly person. And I don't think that's necessarily age discrimination. Okay, anything else? Okay, let's look to the moral dimension of this a bit. Seems to me these are the fundamental moral values from Scripture that govern this. And this is why I think the debate over assisted suicide theologically is kind of a no-brainer. Because you don't take innocent human life because it's God's sacred gift, and because ultimately, at the end of the day, the decision about the timing and manner of a person's death belongs to God. Right? And I would include taking your own innocent life. I would say there's just as big a moral problem with suicide as there is with murder. Right? Now I would treat those situations somewhat differently, but in terms of being morally problematic, I don't see a lot of difference in that. Okay? Scripture also is clear that we have an obligation to protect the most vulnerable. I find it ironic, sometimes tragic, that if somebody in their 20s threatens suicide, the full court press is for suicide prevention. But for somebody who is understandably depressed after a terminal diagnosis, we shouldn't be super surprised about that, that basically all we offer the elderly at the end of life is suicide assistance. And I would consider the elderly, along with the unborn, the contemporary equivalent of the biblical widows and orphans. As in the Scripture, those were used as a figure of speech for the most vulnerable among us. And I think the unborn and the elderly have supplanted the widows and the orphans today as the most vulnerable among us. And if we don't figure out how to do health care better than we're doing it, I'm not thrilled about, my baby boomer generation becoming, the Social Security generation. That's not going to be a happy outcome. Right? Now, to be a little more specific, theologically, we know death entered as a result of sin. Death is not part of God's original design. It was not the way it was intended. But it is true that death is a normal, natural part of life because of the pervasiveness and universality of sin. Right? Now, a culture, when they say death is a normal, natural part of life, what they mean by that is it's morally neutral. But theologically, that's not true. Right? I mean, theologically, death is the ultimate indignity. Right? And if you've walked with a loved one through the end of life, there's nothing particularly dignified about the dying process. I mean, in most cases, it's just downright ugly. The dignity in dying comes from how we cope with our deterioration. By the way, I'm not persuaded that there's anything particularly dignified about an end run around that through assisted suicide or euthanasia. I think that the dignity comes from how you face the difficulties of the dying process. So that, I think the idea, I think theologically, I think the idea of death with dignity is a little different than what the culture means by that.
Yeah.
I think you could probably make an argument that the term death with dignity is almost an oxymoron, theologically, because of death being the ultimate indignity. So death is, we'd say, both an enemy as a result of sin and a normal, natural part of life. However, the good news is that death is a conquered enemy. I mean, that's the last word on the subject. And were it not for the death and resurrection of Jesus, Paul suggests that we are to be pitied because we have no hope. Now, here the question is, I take it this is not breaking news. But what follows from that is really important, it seems to me. And that is, if death is a conquered enemy, then it seems to me that it need not always be resisted. That it's okay to say enough to medicine. Now, we got to be careful about the point at which we do that. But I told my dad, anytime you want to tell these incredibly optimistic oncologists that it's okay to stop, you can do that. And just FYI, under the law, whenever somebody says to stop, that has to, an adult who's with it, that has to be obeyed. If you don't, in California, here, you may be aware of this, in California, you know what happens to a physician who administers a treatment against a patient's will? They're in big trouble. You know what kind of trouble they get in? You know what the charge is?
They take your license away.
Not battery. Wow. It's a battery charge. Okay, now there are exceptions to that, of course, like if it's an emergency or if they're not competent to make their own decisions, then that's different. But most of the time, for a competent adult to say stop, If you don't respect that, you're in deep manure. Right? Now, I think where this cashes out at the end of life is that when a patient's prognosis is very poor, and please, in walking through this with your loved ones, press your physician on the prognosis. I mean, sometimes it's amazing to me. I did a year's rounding project in the ICU at a large Catholic hospital up in the valley. And it was so rare that a physician would actually write down the prognosis. I mean, getting this out of some of these physicians was like pulling teeth. And it's totally okay to press them for the prognosis. And it's totally okay to say, if this was your dad, what would you say to him? Or what decision would you make? And don't let them dodge that question. I think when this is the case, when the prognosis is poor and further treatment is not going to turn this around, then I think we ought to welcome death as the sort of the porch step into eternity. And I think it's wrong to delay somebody's homecoming because we can't let go of them. Okay? When their prognosis is poor and medicine basically can't do much to turn that around, then I think we ought to start thinking less about miracles and more about resurrection. I think this third part, I think making what is left of life more burdensome than beneficial for that person is almost always wrong. And let me give you an example of this. We had consulted on this case some time ago, who was a 95-year-old man. He was in our ICU. You know, what he was doing in ICU in the first place is a good question. But I don't think he weighed more than 95 pounds. He was at the end stage of stomach and colon cancer. And when the case came to the ethics committee, he was being prepped, at the family's request, being prepped for, of all things, a colonoscopy for one last round of treatment. Now, I actually think if you could have held this guy up to a really bright light and probably done the same thing as the colonoscopy would have done. And one of the nurses came to the ethics committee and literally, this is how she put it, she was just exasperated with the whole thing. She said, "Why are we torturing this poor man?" Now the family was in a really interesting position because they didn't know any of this. They didn't know what a colonoscopy was going to do to this man, not to mention the rest of the treatments. Nobody had told them what they were authorizing them to do to this person who they presumably called their loved one. And you think, surely we're not going to allow families to authorize, this kind of mistreatment, which is what it was, mistreatment. Now, they were well-intentioned, but they were also neurotic and unwilling to let go and desperately needing a social worker to come help them sort this out. And finally, we prevailed on them not to do this. But this guy was within probably 30 minutes of a very unpleasant experience. And I will never forget when my father-in-law, he had surgery he had a bladder tumor for years. And in retrospect, we probably should have just left it in there. But he consented, sort of. We pushed him at the physician's assistance to have this tumor, which he said was about the size of a grapefruit, taken out. And he had had complications in the hospital for like 3 or 4 weeks. And I'm wheeling him out as we're going to the car to take him home. And he can't even speak above a whisper. And he motions to me, come close. And he whispered in my ear, he said, don't ever bring me here again. I mean, it's just like, I got it. And what he was saying was, I'm done. I'm done with doctors and hospitals and treatments. And he didn't put it this way, but I think what he really meant by that is I'm going to accept from God's hand whatever days I have left. But sort of what came through between the lines was, don't delay my homecoming. And so couple months later, he had a stroke. And against my better judgment, we took him to the ER, sat in the ER for 4 hours while the neurologist came in and told him that he had a stroke and sent him home. And I thought, that was probably one of the stupidest things we've ever done. So the next time he had a stroke, we didn't take him anywhere. And he had round-the-clock care. And I think we eventually adhered to his wishes to basically be left alone as far as medicine was concerned and to live out his days as God's good gift. And we were sweating the days he didn't have far more than he was. He was ready to go home. Home. And it just took us a while to get that. But I think, had we authorized a whole bunch more tests and treatments and all that, it would have been bad news for making his life more burdensome. Okay. Let me just do one more thing real quick and then we'll take a short break. Here, the general, think about this a little bit over the break and then we can talk about this further. I think it's okay to withhold or withdraw treatments that are life-sustaining when a competent adult requests it. Under the law, you have to do that. And whether they request it in writing or orally is irrelevant. Most of the time, a competent patient will request it when a treatment is futile, or if the burden outweighs the benefit. It may do some good, but the burden is so outweighs it that it's just far more. It's a net burden. It increases the net level of suffering that the patient endures. All right, we'll take a break here. We'll come back and we talk about this a little bit further. And then I want to deal with some of the objections to this that are often raised. Okay? Some are moral, some are more intuitive. Okay?
Biola University offers a variety of biblically centered degree programs, ranging from business to ministry to the arts and sciences. Visit biola.edu to find out how Biola could make a difference in your life.